Hi friends, I'm Dr. Pahuja. I'm the Chief Medical Officer for Aerolib Healthcare Solutions, and today we'll be talking about a primer on condition code 44. We'll talk about a case, some regulations, some question answers, and in the end you'll be able to see all these references. Here's a little contact information for myself. Now we are based in Dallas, Texas. You are seeing this presentation as part of the Aerolib Learning Management System. You all know we have knowledge on Medicare regulations and help hospitals with admission, outpatient beds, observation guidelines, also focus on the importance of documentation. We'll be referring this MLN Matters article that was released in 2004. It's the CR number 3444, and it's to clarify Medicare payment policy when inpatient admission is determined not to be medically necessary, and then talks about the use of condition code 44. This is a decision tree made by a friend, Ernie De Los Santos, who is also a speaker for the Aerolib Learning Management System. You can review this slide at your leisure after we're done with the presentation, print it out, and help yourself in making decisions on when to apply. We'll be talking about this during the course of the presentation. So we all know Medicare has hospital conditions of participation, and they are required to have a utilization review plan. And this is part of the 42 CFR 48230 requirements. Now, the hospital can also fulfill these UR requirements, including the function of a UR committee and responsibilities, through a QIO that the hospital can use. Now, CMS wants that a UR committee for a hospital has 2 or more practitioners that carry out the function. Now, these must be doctors of medicine or osteopathy, and other members may be of any of the other types of practitioners specified in the regulations. The determination that an admission or continued stay is not medically necessary must be either made by one member of the UR committee if the practitioner responsible for the care of the patient either concurs with the determination or fails to present their views, or 2 members of the UR committee in all the cases. So UR committee must consult with the practitioner responsible for the care of the patient and allow them to present their views before making the determination. If the UR committee determines that the admission is not medically necessary, the committee must give written notification no later than 2 days after that determination is made to the hospital, to the patient, and the practitioner responsible for the care of the patient. So let's start with our case. An 81-year-old male presenting from home to the ER at 9 p.m. with 1-day history of resolved slurring of speech and left-sided lower extremity weakness that lasted for 5 minutes. Now, this all started at 3 o'clock in the afternoon. Past medical history is significant for hypertension, COPD, and atrial fibrillation. The initial CT scan of the brain is negative for an acute bleed, and the neurological examination shows no motor or sensory deficits. On day 1, this patient is hospitalized under inpatient for an acute TIA, sent to the neuro floor, and orders for IV fluids, aspirin, echo, carotid ultrasound, MRI of the brain, and neurology consultation. On day 2, this patient feels better, is recommended discharge back to the nursing home in the morning with continuation of aspirin. Later that evening, the hospital's UR committee and attending physician determine that patient did not meet inpatient criteria. So the question is, can the provider bill a condition code 44? The answer is no, since the determination was made after this patient was discharged, and thus the CC44 should not be billed. So in an alternate scenario, on day 2, early in the morning, the hospital's UR committee and attending physician determine that patient did not meet inpatient criteria and was changed to observation. Patient feels better, is recommended discharge back to the nursing home in the evening with the continuation of aspirin. before this patient is notified of the change in determination. Question is, now can the provider or hospital bill condition code 44? The answer is yes. Now, even though the determination was made before the patient discharge, patient was not notified of determination change prior to discharge. Now, it's always a good practice to inform patient of all the status changes. However, it's not part of the CMS regulations at the time of this presentation being made, and thus CC44 can be billed. So condition code 44, now a physician or a state licensed practitioner may order an individual to be admitted to an inpatient bed, but upon subsequent review, a hospital's UR committee determines patient does not meet inpatient admission criteria, and thus this is when the hospital uses the condition code 44 to change this patient's status from inpatient to outpatient before the beneficiary's claim has been submitted. The National Uniform Billing Committee issued the CC44 effective April 1, 2004, and the definition is inpatient admission changed to outpatient for use on outpatient claims only when the physician ordered inpatient, but upon internal UR review performed before the claim was submitted, the hospital determined that services did not meet its inpatient criteria. So for CC44 to occur, all of the following need to be met. 1. The change in patient status from inpatient to outpatient is made prior to discharge or release while beneficiary is still a patient of the hospital. 2. The hospital has not submitted a claim to Medicare for the inpatient admission. 3. Physician concurs with the UR committee's decision. And 4. Physician's concurrence is documented in the patient's medical record. There were a number of questions that arose once this transmittal was released, and I'm listing a few of those. The most commonly asked question was, can a case manager or utilization management staff member change a patient's status from inpatient to outpatient after determining that the hospital's criteria were not met? The answer is no. Case managers or other UR staff personnel who are not licensed practitioners permitted by the state to admit patients or a doctor of medicine or osteopathy will not have the authority to change this patient's status. CMS, however, encourages and expects hospitals to employ case management staff to facilitate the application of hospital admission protocols and criteria, and to facilitate the communication between the practitioners or the QIO, and to assist in the UR committee in making that decision-making process. So use of condition code 44 is not intended to serve as a substitute for adequate staffing of UR management personnel or for continued education of physicians about the hospital's existing policies. Another question is the concurrence of the physician or practitioner acceptable when a hospital has determined that a patient's status should be changed from inpatient to outpatient? Many a times the admitting or the physician responsible for the care does concur, but at times when they don't, the criteria are not fulfilled. Now, concurrence is a prerequisite for the use of this criteria. So how should the hospital bill Medicare if the criteria for using condition code 44 are not met, but all requirements in the condition of participation have been complied with? In this particular case, if the CC44 conditions are not met, hospital should submit a bill using type of bill 12X for covered Part B only services that were furnished to this beneficiary. Now, how should the change in patient status from inpatient to outpatient be reported in the patient's medical record? Can the hospital just discard the inpatient record? The answer is no. Entries in the medical record cannot be expunged or deleted. They must be retained in their original form. Therefore, all orders and all entries related to the inpatient admission must be retained in the record in their original form. These were some of the most commonly asked questions. A lot can be found on the CMS website. You can see these links, click on them and read more about this. Thank you.